Welcome all. Today's topic is surgical site infection, prevention and treatment. This is a NICE guideline published in April 2019. We begin with our quote, Master MRCOG with concept-oriented clarity. So what is the surgical site infection? So the definition of surgical site infection, it is an infection which is occurring at or near the surgical incision. It occurs within 30 days of surgery or within 1 year if the implant is used. Okay. As far as gynecological procedure is concerned, we are operating and without implants mainly. So it is 30 days. But if it is with implant, it is up to 1 year. Okay. It includes superficial incisional, deep incisional, and the organ space infections. So actually, it is one of the healthcare associated infection. So what is surgical site infection? It is one of the healthcare associated infection. It occurs in surgical wound after the invasive procedure. And what are the other healthcare associated infections? Like post-operative respiratory tract infections, urinary tract infections, bacteremia may be related to the MRSA or IV cannula related infections, or antibiotic associated diarrhea, especially Clostridium difficile. These are healthcare associated infections, and one of them is a surgical site infections. And what is the burden? They can ask you this for SBA. SSI accounts for up to 20% of all healthcare associated. So 1/5 of all HAI, that is healthcare associated infection, is surgical site infection. And among all the surgeries, 5% of the surgeries are likely to have these SSI. Okay, so if you consider only surgery, it is up to 5% or more patients will have SSI. And among all healthcare associated infection, it is around 20%. That is 1 in 5. Okay, and this is 1 in 20. That is 5%. Remember this. Sometimes we remember 5%, but they give you 1 in 20. That itself is 5%. Okay. Now, what are the risk factors for surgical site infections? The factors can be patient-related or the procedure-related. Patient-related factors like diabetes, which is poorly controlled, obesity, smoking, malnutrition, immunosuppression, that the patient is on steroids, chemotherapy, or patient is HIV, and anemia. These are patient-related. Procedure-related are prolonged duration of surgery, emergency surgery, poor aseptic technique, inadequate or inappropriate antibiotic prophylaxis, poor perioperative temperature control, etc. Okay. So that these are the risk factors for surgical site infection. Now, what does the guideline tell about the antibiotic prophylaxis? So here, actually, on this particular NICE guideline, they can give you the options. As per the NICE, this is recommended. So you should know what exactly is recommended in that situation. So what does the guideline say about the antibiotic prophylaxis? The NICE recommends that antibiotic prophylaxis should be given within 60 minutes before the incision, and it is a single dose to be given within 60 minutes prior to the incision. Okay. So intraoperative measures, there are specific things about the skin asepsis. Here again, there are SBAs which are asked on the skin asepsis. So what is preferred for skin cleaning? It is a alcohol-based chlorhexidine which is preferred. Remember, alcohol-based chlorhexidine is preferred. Alternative is a providone iodine if chlorhexidine is contraindicated. Okay. Application allowed to dry completely before the incision. Okay, alcohol-based solutions reduce surgical site infection more effectively than aqueous-based. So when you have these solutions, they may give you alcohol-based and aqueous-based. So you will always prefer the alcohol-based chlorhexidine because alcohol-based solutions will reduce the SSI more effectively than the aqueous. If the patient is allergic to chlorhexidine, then you will use a providone iodine. Okay. So maintain normothermia and adequate oxygenation during the surgery. So these are the intraoperative precautions which are to be taken. So first choice, unless contraindicated, surgical site is unless contraindicated or surgical site is adjacent to the mucous membrane, you will choose alcohol-based solution of chlorhexidine because this alcohol-based agents are contraindicated near the mucous membrane. So the surgical site should not be near the mucous membrane. Or this alcohol-based solution, unless it is contraindicated, we will use alcohol-based solution of chlorhexidine. Okay. Then surgical site is next to the mucous membrane. Then you will not use alcohol-based. Then you will use aqueous solution of the chlorhexidine. So whatever is the scenario or the question says, what is the site where you are operating? Okay. If it is near to the mucous membrane, you will use aqueous solution of chlorhexidine. So the chlorhexidine is first. In that also alcohol based. If the alcohol base is contraindicated, then or the surgical site site is near to the mucous membrane, go for aqueous solution of chlorhexidine. Okay, chlorhexidine is contraindicated, then you will go for alcohol based solution of providone iodine. But if both alcohol based solutions and chlorhexidine are unsuitable, then you will go for aqueous solution of providone iodine. Okay, remember this particular sequence completely. Okay, which will you choose? The first will always be alcohol based solution. If the mucous membrane, you will use aqueous chlorhexidine. If chlorhexidine is contraindicated, you will go for alcohol based providone iodine. But if the alcohol based solution and chlorhexidine both are cannot be used, then you will use aqueous solution of the providone iodine. Okay, now they can confuse you with the percentages of these. Okay, so the next slide talks about certain percentages. Chlorhexidine in alcohol. Remember, alcohol here is always 70% alcohol. So when you are selecting the right option here, you are selecting the properly. Then select the percentage also properly. Always look for 70% alcohol. Okay, and chlorhexidine is in two form: 0.5% chlorhexidine and 2% chlorhexidine. Okay, this 5% of 0.5% chlorhexidine is for minor surgical procedures, and 2% is for skin disinfection before invasive procedure. Okay, so other chlorhexidine alcohol combinations are not licensed. Prescriber takes the responsibility. Now next is aqueous chlorhexidine. So here the percentage is 4%. Okay, so this is used for preoperative and postoperative antisepsis. Okay, so these percentages for aqueous, there is a little high percentage, and alcohol based, it is a 70% alcohol, and the chlorhexidine maybe 0.5%, maybe 2%. Okay, the 2% is for skin disinfection before the invasive procedure, 0.5% for minor surgical procedures. Now coming to the providone iodine. Providone iodine, remember 10%. It comes in two strengths, 10% and 7.5%. First is a alcohol based. Okay, 10% providone iodine. It is for topical skin antisepsis. So this is always we prefer 10% providone iodine. Okay, 7.5% is preferred for surgical hand scrub and preoperative skin preparation. Okay, so 7.5% is mainly for surgical hand scrub. Okay, and this is aqueous providone iodine. Sometimes we may have to go for aqueous, which situation both alcohol based solutions and chlorhexidine they are not suitable, then you will go for aqueous solution. Okay, even if the site is close to the mucous membrane, in that particular case you will use aqueous, but first choice will be the chlorhexidine, next choice will be the providone iodine. Okay, so that can also be used to the skin and mucosal antisepsis, but the priority will be as we have seen in the previous slide. Okay, so is this clear to you, percentages?
Yes, sir.
Doctor?
Yes, sir.
Yeah. Okay, so remember iodine antiseptic 10%, intact mucosa and skin. Providone iodine scrub 7.5% for surgical hand scrub and incision site. Providone wash 7.5% for staff scrubbing and patient skin preparation. Providone iodine solution 10% for pre-operative and post-operative skin cleanser. Now they have classified the wound. Wound is classified as a clean, contaminated and dirty or infected. So these are the classification of the wound. What is clean wound? It is an incision with no inflammation, no break in the sterile technique, and no entry into the respiratory, alimentary, or genitourinary tracts. Okay, so it is elective surgery, intact sterile field, and lowest risk of surgical site infection. That is a clean wound, and clean wound does not require a prophylactic antibiotics routinely. Most of our surgeries fall into this clean contaminated. Okay, so what is clean contaminated? It is a controlled entry into the respiratory, alimentary, or genitourinary tract with no contamination. So you are controlled entry means under all aseptic precautions, you are entering into the respiratory, alimentary, or genitourinary tract, but there is no contamination. Like elective hysterectomy, bowel or vaginal surgery, or entry under controlled conditions. That means strict asepsis is maintained. Okay, so for clean and contaminated, prophylactic antibiotics are indicated. For dirty wounds, established infection, antibiotics are therapeutic. Okay, here there is a role of therapeutic, while here only prophylactic, single dose of antibiotic within 60 minutes prior to the incision. Okay, and traumatic wounds more than 12 or 24 hours, they are contaminated or dirty. Okay. Now, next classification type of wound is a contaminated. That is surgery with major break in the sterility. There is a gross GI spillage or acute non-purulent inflammation. That is a bowel spillage or traumatic wound more than 12 to 24 hours. And these will increase the surgical site infection risk. Which are the dirty wounds? That is surgery with perforated viscera, pus, or established infection. Examples are fecal peritonitis, abscess surgery, delayed traumatic wounds with contamination. Okay. So clean wound, no entry. Okay. Second, clean contaminated, controlled entry. Third, contaminated is a spillage or break. Dirty is a pus or perforation. Okay. So these are the buzzwords you can remember. Now, what are the intraoperative measures during the surgical technique? So there has to be gentle tissue handling, effective hemostasis, avoids dead space, and use sterile instruments. Wound irrigation in intracavity lavage. What does the guidelines say? Do not use wound irrigation to reduce the risk of surgical site infection. So wound irrigation is not indicated. Do not use intracavity lavage to reduce the risk of surgical site infection. Even the intracavity lavage is not indicated. Okay. Then diathermy versus scalpel. No strong evidence favoring one or the other for surgical site infection prevention. Choice is based on surgical judgment. Okay. Then wound closure and dressing. Closure method. Sutures are preferred over the staples in cesarean section. Dressing use standard sterile dressing is indicated. Okay. Post-operatively. So use antiseptic non-touch technique when you are changing the dressing or removing the dressing. So ANTT, antiseptic non-touch technique. You are changing the dressing or removing the dressing. Antiseptic non-touch technique. Aim is to prevent the introduction of the microorganism. Then post-operatively, if the wound is to be clean, then for first 48 hours, use sterile saline. For first 48 hours, so these are all SBAs which can be asked. For first 48 hours, the cleaning will be with the saline. After 48 hours, patient can have a shower and use tap water after 48 hours only if the wound has separated or wound has been opened to drain the pus. So this after 48 hours, tap water can be used if the wound is separated or wound has been opened to drain the pus. First 48 hours, only saline. Okay. So topical antimicrobial agents, if the wound is to be healed by the primary intention, then do not use topical antimicrobial agents on surgical wounds healing by the primary intention. There is no reduction in the surgical site infection risk. Okay. So most of the time after the before the dressing, you apply some antimicrobial, which is as per the NICE not required. Okay. Now, if the wound is healing by the secondary intention, then what is to be used and what is not to be done? Do not use Usol and gauze, moist cotton gauze, mercuric antiseptic solutions. Like some infected wound, we do the dressing, and there, what do they say? Don't use Usol gauze or moist cotton gauze or mercuric antiseptic. These are not, as per the NICE, not required. What is recommended is appropriate interactive dressing. Seek advice from the tissue viability nurse and specialist with wound care expertise. So expert's opinion is required and interactive dressing is required. That's all. However, these Usol gauze, moist cotton gauze, mercuric antiseptics, these are not required. Okay. Now, antibiotic treatment. If SSI is suspected like cellulitis, you will start with systemic antibiotics. And antibiotic choice will depend on the likely causative organisms, local antibiotic resistance pattern you need to take into account. If the microbiology report is available, that you will take into account and follow antimicrobial stewardship principles. For debridement, do not use Usol and gauze, dextranormer, or enzymatic treatments for debridement in the management of surgical site infection. Okay. Now, what is the summary for post-operative care? Antiseptic, no touch technique for all dressing changes, sterile saline up to 48 hours. Showering is permitted after 48 hours. No topical antimicrobials for primary intention wounds. Interactive dressing and specialist input for secondary intention. Systemic antibiotics for suspected surgical site infection. Avoid use of gauze and enzymatic agents, and emphasis is on governance, stewardship, and structural care. Okay, so that finishes the topic of NICE surgical site infection. Thank you.